Hello everyone. This is Maithili Anand Deshpande, an intern from Vedak Dental College and Research Center in Nanidaman. And today we'll talk about myofunctional appliances, more briefly about activator and bio. Let us begin. So we all know that myofunctional appliances are based on the principle of application or elimination of forces to bring about musculoskeletal development. Now since we're talking about activator and bionator, let us begin with activator first. Now activator is a loose-fitting, removable, myofunctional appliance that was given by Vigo Anderson. It is synonymous with the terms monoblock, Anderson and Hoppel appliance, Anderson appliance, and Norwegian appliance. Now, it has quite an interesting history, starting with Kingsley first introduced it in the year 1876 and called it vulcanite palatal plate. He used it in patients with protruded mandible. It consisted of a plate with an anterior incline to guide the mandible to a forward position. Later on, Hodds introduced Vorbis plate, which was a modified form of Kingsley's plate, and he advocated it to use in cases to treat retrognathism associated with deep bite or retrognathism associated with lingually inclined lower incisors. Later on, Pierre Robin introduced the term monoblock because it was a single block of vulcanite, as both the maxillary and the mandibular acrylic components literally fused together to form a single block. He used it to position the mandible forward in patients with glossoptosis, that is abnormally positioned tongue, and severe mandibular retrognathism. He observed that the use of activator reduced the risk of airway obstruction quite significantly. Now coming to the main author, Vigo Anderson, who introduced the activator as we know of today in the year 1908. His daughter was under fixed appliance therapy. Now he removed his daughter's fixed appliances and replaced it with Hawley's type of maxillary retainer and placed a lingual horseshoe-shaped flange on the mandibular teeth that guided the mandible forward. After she returned from her summer vacation, he was shocked to know that her class 2 malocclusion was completely eradicated. He later modified his appliances using a wax bite to register the mandible in advanced position while treating children in Norwegia, where he was working at the University of Oslo along with Carl Hoppel. They came up with a system and named it Norwegian system, or the functional jaw orthopedics. Since the original name for this kind of treatment was biomechanical orthodontics, this appliance was also known as biomechanical working retainer. It was later named activator due to its ability to activate the muscle forces. Now let us talk about the mechanism of action of activator. There are three known basic concepts. The first one is myotatic reflex, second is the viscoelastic property, and the third one is the transitional concept. Talking about the myotatic reflex, since the patient moves his mandible forward to engage the appliance, this results in stretching of the elevator of muscles of mastication, which starts contracting and thereby setting a myotatic reflex. You can appreciate in the image the stretching or the activation of the muscles of mastication. Now this leads to generation of kinetic energy, which causes three things. First is prevention of further forward growth of maxillary dentoalveolar process, because there will be an opposing force on the maxilla. Second, the movement of maxillary dentoalveolar process distally. And the third is the reciprocal forward force on mandible. This occurs due to transferring of the forces to maxillary and mandibular teeth through the acrylic body and the labial bow of the activator. From teeth, these forces are transmitted to periosteum and bone, producing restraining effect on the forward growth of maxilla, popularly known as the headgear effect of maxilla. This leads to a simulation of mandibular growth. Now coming to the second concept, which is the viscoelastic property. Now according to Howard, Woodside, and Heron, passive tension caused by stretching of muscles, soft tissues, or tendinous tissue, or simply the forces generated while swallowing and sleeping result in action by a viscoelastic property. Each application of force induces secondary forces in tissues, which result in activation of a whole bioelastic process important in stimulating the skeletal adaptation. Now the third concept, as the name suggests, is transitional. Both the muscle contraction and viscoelastic properties of soft tissue are alternatively utilized. Hence both the kinetic and potential energies are put to use. Talking about the indications of activator, it is indicated in class 1 malocclusions with deep bite or open bite. It is also indicated in class 2 malocclusions in division 1 and division 2 cases. But in case of division 2, it can only be advocated after aligning the incisors. It can also be advised to be used in class 3 malocclusions or mild crossbite corrections. Now, it can be used as habit-breaking appliance, mostly pressure habits that include mouth breathing or tongue thirsting. It can be used as a retentive appliance, and it can also be advocated in patients with obstructive sleep apnea. It can be used as a space maintainer in mixed dentition since the acrylic is extended into the missing tooth space and maintains that space. It can also be used in snoring patients because mostly the pathology behind it is the retruded mandible. Moving forward to the contraindications of the appliance, it is contraindicated in crowded arch. We avoid to use it in cases of increased lower facial height, extreme vertical mandibular growth, or hyperdivergent patients. We avoid the use of it in severely procrine lower incisors or subjects with nasal stenosis. We do not advocate its use in non-growing patients, and we avoid it in cases of retroclined maxillary incisors or cross-bite tendencies. Cross intra-arch irregularities, when observed, are not indicated for the use of activator. Now, as any other appliance, activator has its own advantages and disadvantages. Talking about the advantages, the foremost and the most important is the utilization of jaw growth in desired direction. Second is the appointments are short due to the minimal adjustments that are required, and the interval between the appointment are quite long. The oral hygiene is also acceptable because the appliance is removable, and hence the hygiene can be maintained of both the appliance and the oral cavity. Now, it is possible to treat primary as well as early and late mixed dentition problems. Tissues are not easily injured, and it eliminates pressure habits, as discussed earlier. Coming to disadvantages, first is the success of the appliance depends highly on patient compliance. Since it is a removable appliance, it depends greatly on the wear time. Also, it gives poor response in older adults since the growth is completed. It cannot control forces on individual tooth, and precise detailing and finishing of occlusion cannot be achieved, and hence it may require fixed therapy in future. Also, it cannot be advocated in hyperdivergent patients. Now, coming to the appliance construction, there are various steps starting from the preparation of models of both working model and study model. Then we record a bite registration, while we consider both horizontal and vertical components, which we will discuss in detail shortly. Then comes the articulation of the model, then wax up and wire binding, followed by processing of the appliance, and at the end, selective trimming of the appliance. Now, let us talk about the construction bite. So, a construction bite is a process by which the position in which the functional appliance has to be processed is registered. Now, there are certain guidelines for it. We will discuss it. But firstly, let's understand the different types of the construction bite. First one is the low construction bite with marked mandibular forward positioning. Second is high construction bite with slight mandibular forward positioning. Then construction bite without mandibular forward positioning, and construction bite with opening and posterior positioning of the mandible. Now let's talk about the guidelines. When these bite registrations are recorded in early mixed dentition cases, the mandible is to be moved forward until the upper canine relates directly above the interproximal between lower primary canines and the first primary molars. On average, this is 4 to 5 mm. In late mixed dentition period, the mandible is to be moved forward until the upper primary canine relates directly above the interproximal between lower cuspid and first bicuspid. On average, it is 6 to 8 millimeters. Now, considering the anterior midline, this is very important. When the bite registration is taken, the upper and lower midlines should coincide properly. Now, if there is a skeletal discrepancy in the midline, bite registration is done with midline coinciding. But if there is a dental midline deviation present, no attempt for correction is to be made. Now, let us discuss the different types individually. Firstly, we have low construction bite with marked mandibular forward positioning. Marked sagittal advancement is done here. That means the forward positioning of the mandible, but minimal vertical opening is done. Now, as you can appreciate in the image, the yellow color marking is the minimal vertical opening, and the green colored marked mandible is quite forwardly positioned. This type is known as the H activator or the horizontal activator, and it is indicated in class 2 division 1 malocclusions having a horizontal growth pattern. In these cases, while bite registration, the mandibular advancement that we make is around 6 to 7 millimeters, while the vertical opening is 3 to 4 millimeters. Moving forward, we have high construction bite with slight mandibular forward position. Now, in this case, there is minimal sagittal advancement, that is the forward movement of mandible, but marked vertical opening, as you can appreciate in the yellow color. Now, this type is known as the vertical activator or the V activator. and it is indicated in class 2 division 1 malocclusions having vertical growth pattern. Now here we take the mandibular advancement of about 2 to 3 millimeters, while the vertical opening is 7 to 8 millimeters. Now we have construction bite without mandibular forward positioning. No sagittal advancement is made, only marked vertical opening is maintained. Now this is indicated in deep bite and open bite cases. Moving forward, we have construction bite with opening and posterior positioning of mandible. Now there is marked sagittal advancement but in retrograde position. That is, the mandible is taken backwards rather than forwards, and the vertical opening is just sufficient to clear the bite. Now this type is known as a reverse activator, and it is indicated in class 3 malocclusion cases. As you can appreciate in the image, the yellow color is just sufficient vertical opening, and the green color, the mandible is taken backwards rather than forwards as in other cases. Now we have to consider two main things, that is the rule of 10 and the rule of thumb. Because when we decide the vertical opening or the sagittal advancement, how to decide that how much millimeter we are taking the forward positioning and how much vertical opening is to be made. This decision can be done by following the rule of 10, which states that the maximum amount of sagittal advancement and vertical opening should add up to 10 millimeter. Which means if I am making a sagittal advancement of 6 to 7 millimeter, the vertical opening should be maintained around 3 to 4 millimeters. Now also we have to consider that if the overjet is too large, stepwise sagittal advancement is to be made into 2 to 3 phases. This is according to the rule of thumb, which states that the anterior advancement should not exceed more than 3 millimeters posterior to most protrusive position. Hope that is clear. Now moving forward, this is the procedure of how to register a bite. Now firstly, the sagittal advancement and the vertical opening should be planned. After that, a horseshoe-shaped wax block of 2 to 3 millimeter thicker than the planned vertical opening should be prepared. Before recording, we should practice the forward positioning of the mandible with the patient and guide him. Now while recording, the patient should be seated upright, and the wax block then is placed between the maxillary and the mandibular teeth and gently pressed so as to form indentations. This bite is then removed and placed on the model and checked. If it is alright, it is chilled and then again tried on the cast. Now if you're satisfied with it, the excess of the wax is trimmed off and the hardened wax block is again tried in the patient's mouth. Moving forward to this image, the first one is the wax block on the cast. In the second one, you can appreciate that particular wax bite in the patient's mouth. And in the third image, you can appreciate the incorporation of the labial bow as well. See, for bite registration, we'll first mark points on both the side of the cast. This is the amount of vertical opening that we require and we plan. We measure it. Now we take two reference points, mostly the tip of the nose and a point on the chin. He is drawing the midline. So midline should coincide while bite registration, right? So here we take a wax sheet, we put it in a hot water bowl and we roll it to form a wax block. It is adapted in the arch form and placed on the cast to form indentations on it. We also mark the midline and two reference lines. Now this wax is placed in the patient's mouth and the mandible is guided forward and the bite registration is recorded. He made sure that the vertical opening and the measurement was accurate. Then the wax bite is tried on the cast. If satisfied with it, we trim off the excess, and that is how it is done. Hope it is clear now. Coming to the components, we have both wire components and the acrylic components. For activator, the wire components consist of an upper labial bow, which may either be active or passive depending on the treatment protocol, and it is made up of 0.8, 0.9 mm wire. It consists of a horizontal section and two vertical loops like any other labial bow, and the ends of the vertical loops enter the acrylic body between canine and deciduous first molar. The word deciduous here is of quite importance because mostly these myofunctional appliances are given in growing patients. So here we are advocating it either in early or late mixed dentition periods. Now coming to acrylic components, it is widely divided into maxillary part, mandibular part, and interocclusal part. We can better understand it with the help of this image. Now the component of acrylic that is in contact with the gingiva is the gingival element, and the part of acrylic that is in contact with the tooth is the dental element for both the maxillary or the mandibular part. And the acrylic that flows between the occlusal surfaces of the maxillary and the mandibular teeth is known as the interocclusal part. Let us now see the fabrication of activator. Firstly, the fabrication of the vial elements. When we are done with that, we stabilize it with wax. In here, we prepare a wax shield that will not allow the acrylic to flow through. Can you appreciate the wax stabilization that is done here? Now we proceed to the application of cold mold seal and then acrylization. We can use both heat cure or cold cure resin. After acrylization, this is how the appliance looks. Now we pour hot water for dewaxing and easy separation of the appliance from the cast. This is how it looks now. The next step is to trim the appliance. All the excess acrylic is removed and a particular shape is given to the appliance. This is how it looks post trimming. Now you can compare it to the window on the left side, how it looked before trimming and how it is after trimming. Now we'll proceed to finishing and polishing. This is what the application looks after the finishing and polishing. Now let's try it on the cast and see how it looks. This is how it fits. I hope it's clear now. Now talking about the trimming. After the insertion of the appliance, we have to selectively trim the appliance in all the three planes to bring about the dentoalveolar changes. Of course, whenever we talk about orthodontics, all the three planes has to be always considered. Now, while trimming, we can achieve vertical control, sagittal control, and transverse control. In vertical control, we can bring about intrusion and extrusion. In sagittal control, we can bring about protrusion and retrusion of incisors, of course, and distal movement of molars and nasal movement of molars. And in transverse control, we talk about expansion. Now for vertical control, intrusion cases for incisors, we load the incisal edges. Loading means application of the acrylic over there, and it is recommended in deep bite cases. You can appreciate it in the image besides, where the molars have the acrylic between the occlusal surfaces. This will force them to intrude. Now for molars, the cusp tips are loaded and the fossas and fissures are kept free from acrylic, as you can appreciate in the image. For extrusion, the loading of the lingual surfaces above the contact point is done for incisors, as you can appreciate in the lower image, while for molars, loading of lingual surfaces above the point of contact in maxilla and below in mandible is done. This is also quite clearly shown in the image beside it. This will allow the extrusion of the molars and incisors, however and whenever required. Moving forward to sagittal control, we have protrusion, retrusion, distal movement, and mesial movement. Now for protrusion, we load entire lingual surface of the incisors. This will cause the forward movement, that is protrusion of incisors. And for retrusion, we trim off the acrylic from the lingual surface. For distal movement of the molars, we load the mesiolingual surfaces of the molars. Now since the distal surfaces are free from acrylic, the movement can occur in that direction. Similarly, for mesial movement of molars, we load the acrylic on distal surfaces and keep the mesial ends free. This will cause the mesial movement of the molars. Now coming to the transverse control, it can be done by allowing the contact of the acrylic on lingual surfaces of teeth to be moved transverse, as you can see in this image. This will cause the transverse control. Now let's talk about the retention period. The retention period here begins when the bicuspid exchange is completed and adult class 1 occlusion is established. The average duration of retention is 6 to 8 months, followed by active treatment. Now, after these 6 to 8 months, the wearing of appliance is gradually tapered off over a period of 2 to 3 months. And the wear time advocated is 2 to 3 hours during the first 2 weeks, while followed by full nighttime wear. Now, talking about clinical assessment, whenever we advocate a patient with a myofunctional appliance and he comes back to you, how can you check whether the patient is regularly wearing it or not? There are 3 points. The first one is the pterygoid response. Now, since the lateral pterygoid muscle is majorly involved in this myofunctional appliances, the movement of the mandible goes on continuously to be in the forward position. Now, as it is adapted in that particular direction, after the continuous wear of appliance, when you take your mandible backwards, there is a pain felt behind the condyle, and this is known as pterygoid response. You can check for it. Now, the second one is salivation. Whenever anything new is introduced into the oral cavity, there is excess of salivation. Now, when we are clinically checking the patient and you observe excess of salivation in the mouth, this is an indication that the patient is not regularly wearing the appliance, while it will be normal if the patient is regularly wearing it. The third is the palatal marks. Now, these marks can be observed on the palate if the patient is regularly wearing the appliance. Let's talk about the treatment effects now. We broadly divide it into skeletal, dental, and soft tissues. Now, skeletal changes in relation to maxilla, we observe there is a slight intermolar expansion of the arch, there is slight intercanine expansion, and the popularly known headgear movement of maxilla, that is the restraining effect of the maxillary arch as a unit. Now, in mandible, there is no change in the intercanine width, but there is an increase in downward and forward translation of the mandible as a unit. Talking about the dental changes, there is retraction of the upper incisors, increase in the vertical height of posterior teeth of both the maxillary and the mandibular unit, and proclination of the lower incisors, and reduction in deep bite. In regard to the soft tissues, there is change in lip posture, where the potentially competent lips become sufficiently competent. Here is an image where you can appreciate the deficient mandible has been corrected, the profile has been corrected, and the lips have become sufficiently competent. This is a video where you can better understand the functioning of the activator. This is the activator in a class 2 case. Now, after it is advocated, this is how the bite is slowly corrected. By selective trimming, we create open bites and close them selectively, and a perfect occlusion in relation to the case is achieved. Moving forward, these are the modifications of the activator. The bow activator of A.M. Schwartz, Wondrous modification, reduced activator, cybernator of Schmuth, propulsor, Potts, cutout palate-free activator, Kavitsky modification, type 1, 2, and type 3, Heron-Shea activator, activator of Shea, Louisiana activator, elastic open activator, elastic activator for open bite, combined labial bow of Bachelor, Hamilton expansion activator, Patrick's modification, Eckermann fixed appliance activator, Tuchus activator, Van Beek activator, and magnetic activator device. These are the images. The first one is the Binder's modification. The second image is of Anderson activator, and the third image is for the open bite appliance. Now moving forward to Bionator. Bionator can be introduced as activator-derived removable myofunctional appliance. since it was introduced to cover up for the drawback of activator that is being very much bulky. Now, bionator was introduced by Professor Wilhelm Balters of Germany in early 1950s, also referred to as skeletonized activator. Now, it works on the principle of elimination of muscle action, mainly the buccinator and tongue, but also orbicularis oris has its own function. This aids in the appropriate dentoalveolar development. Now, whenever we talk about activate bionator, the philosophy has to be mentioned. According to Balters, the equilibrium between the tongue and the circulo-oral muscles is responsible for the shape of the dental arches and the intercuspation. Also, the role of tongue is considered very, very decisive. The objectives that we have are elimination of the lip trap and abnormal relationship between the lips and the incisor teeth, elimination of the mucosal damage due to traumatic teeth bites, correction of tongue malposition and associated mandibular retrusion, and attainment of correct occlusal plane. As you can understand from this image, we have orbicularis oris anteriorly and buccinator mechanism from both the side, while we have tongue in the center region. All of these musculatures surround the dentoalveolar component. Now, let us try this exercise. You try to take your mandible forward and backward. You can do that. Now, take your tongue forward and backward without moving your mandible. Do you observe that it is not possible? So this is how the musculature affects the dentoalveolar structures. Now we talk about the mechanism of action. For bionator, the principle of treatment is not to activate the muscles, but to modulate the muscle activity in an attempt to enhance normal development. The purpose of bionator is to establish good muscle coordination and eliminate potentially deforming growth restriction, unloading the condyle through a protrusive mandibular position. Now, as we talked about the musculature, even in prosthodontics, while teeth arrangement, we talk about the neutral zone to avoid any of this musculature, right? So, even in orthodontics, we avoid the excess force of this musculature and allow the proper development of the dentoalveolar structures. Now, in class 2 cases or class 3 cases, this is how the whole thing works. In class 2 cases, the backward positioning of tongue is observed. So, this generates a faulty deglutition and mouth breathing tendencies are increased. Now, bionator brings the tongue forward, and this happens by the stimulation of distal aspect of dorsum of the tongue by posteriorly directed palatal arch wire. This is the very important function of the palatal arch wire, which we will also discuss later. The interior development of mandible induced by H construction bite. Now, in class 3 cases, this palatal arch is inverted with round bend directed anteriorly. This causes the tongue to be trained by the proprioceptive stimuli to remain in a more retracted position. Now, let's talk about the types and their components. Bionator are basically of 3 types. The first is a standard appliance, which is advocated in class 2 division 1 cases mostly. Second is the screening appliance or the open bite appliance. It is used for elimination of abnormal tongue activity and open bite cases. And the third is the reverse appliance, which is used for the treatment of class 3 malocclusions. Now, as any other appliance, we have wire and acrylic part. This is how it is. The first one is the palatal arch wire. Now, the palatal arch wire is always placed 1 mm above the palatal surface. Second is the vestibular wire, which goes backwards and forms the buccinator loop. As you can see in the image, it is marked the second number. Third is the maxillary acrylic. Fourth is the mandibular acrylic component. And fifth is the interocclusal acrylic. Now, for standard appliance, when we talk about the acrylic component, it has a flange of acrylic covering the lingual aspects of mandibular dental arch, but only small palatal areas of maxillary molars and bicuspids. Now, the acrylic block is minimal extent and thickness so as to not encroach into the tongue space. It starts from the distal of the upper canine to 2 to 3 millimeters behind the first molar. It covers only 2 to 3 mm of mucosa above the gingival margin of upper and lower posteriors. The maxillary and the mandibular teeth are joined by interocclusal acrylic block, which extends over half of the occlusal surface of teeth. Can you see this in this image? Now let's talk about the vestibular wire. It is made up of 0.9 mm wire, and the labial portion is first ideally adapted and does not touch the incisor teeth surface. At distal of the lateral incisors, you can simultaneously observe it on the image. Now at the distal of the lateral incisor, the wire bends downwards and distally to form a buccinator loop. This loop runs along the middle of the crowns of the posterior teeth, around 3 millimeters away from the tooth surface. And these loops extend as far as the embrasure between the deciduous second molar and first permanent molar of the maxillary arch. And from there, it takes a 90-degree rounded bend and runs along the crowns of embrasure between the canine and the first molar or premolar, and here it gets encroached in the acrylic here. Now the functions of the vestibular wire are: first, the buccinator bend acts as a vestibular shield, like in a functional regulator, which prevents the soft tissues of the cheek from intruding into interocclusal spaces. Second, it facilitates the eruption and the occlusal plane leveling in buccal segments. It also encourages transverse expansion of the maxillary dental arch by holding the internal surface of orobuccal capsule laterally. It is indicated in treatment of class 2 division 1 and class 1 with narrow dental arches. Now let's understand the palatal arch. It is made up of 1.2 mm wire, and the course of the wire is as follows. You can simultaneously observe it in the image. It originates near the maxillary canine or the first premolar embrasure, rises vertically to the vault of the palate, and at the level of first premolar or molar, it turns distally to form a palatal loop. Now, this extends up to the level of distal aspect of first permanent molar, and this loop is egg-shaped, horizontal, and 1 mm clear of mucosa adapted to follow the contour of the palate. The functions of the palatal arch include the stabilization of the appliance, and it encourages the tongue and the mandible to adapt to a more interior position. Let's see the fabrication of bioneedle. This is the wax bite that is recorded in the patient's mouth. It is positioned on the cast. Then it is articulated. We'll make the markings of bioelements that is prefabricated. In the extent of the acrylic, these are all the markings for the vestibular loop. Wax. These are the 3-prong pliers used for the fabrication. Then coppinder. The coppin spring has to lie 1 mm above the palate. This is how it is stabilized. With the help of the wax. Fabrication of the labial loop or the vestibular wire, which eventually forms the buccinator loop. Now this is how it goes around. It gets embedded in the acrylic. This is the acrylization. This is how it comes out, and after polishing and polishing, this is the completed biomet. Now let's talk about screening appliance or the open bite appliance. Here, the labial book crosses the interincisal area. Lingual acrylic extends into upper incisal region as a lingual shield to prevent tongue thrusting, which is quite functional in open bite cases. This is used to inhibit abnormal posture and function of tongue, and to do so, the maxillary acrylic portion is modified so that even the interior area is covered. Now talking about the reverse appliance, it is used to encourage the development of maxilla. It is advocated in cases of mandibular prognathism, that is class 3 malocclusion cases. The lingual shield acrylic is extended behind the upper incisors to guide them forward. The labial bow runs in front of the lower incisors instead of upper to restrict their proclination, and the palatal bar runs forward instead of posteriorly. Reason being an attempt to stimulate the tongue to remain in a retruded position. Yet again we talk about the palatal bar. Very, very important. Now this is a tabular representation of the differentiation of the different types of bionator. Now we'll talk about each component. Considering the palatal arch, in standard appliance, it runs backwards and distally, similarly in screening appliance. But for reverse activator, the palatal arch runs forwards instead of posteriorly. Now, vestibular wire. In standard appliance, the labial bow is ideally shaped and it does not touch the lower incisor teeth. In screening appliances, it crosses the interincisal area. And in reverse activator, the labial bow is in front of lower incisors instead of upper. So it moves downwards and downwards. Now, acrylic component in standard appliance. The maxillary and the mandibular teeth are joined by the interocclusal acrylic block, and it extends over half of the occlusal surface of teeth. The acrylic covering lingual aspects of mandibular dental arch. Only small palatal areas of maxillary molars and bicuspids. In screening appliance, the lingual acrylic extends into the upper incisor region as a lingual shield, and maxillary acrylic portion is modified so that even the interior area is covered. When reverse activator, the lingual acrylic extends into the upper incisor region as a lingual shield. Now, standard appliance is indicated to correct class 2 division 1. Screening appliances are used to eliminate abnormal tongue function or in open bite cases, and the reverse activator is advocated in class 3 malocclusion cases. Right? Now, to think about what will you do when we already have proclined incisors. To prevent the further proclination of incisors, we can place acrylic block that will cover the incisors, capping of the incisors, right? Now coming to indications of bionator, it can be advocated in class 2 division 1 malocclusions. It can be used as a retentive appliance. It can be used for treatment of open bite due to functional causes. It can be advocated in correction of class 3 malocclusions due to retrognathic maxilla. It can be used to correct TMJ problems, and it is also advocated in mixed dentition associated with habits or abnormal tongue function. Its contraindications include labial flaring of lower incisors wherever it is present. Then in interior crowding patients, it is not advocated. It cannot be advocated in vertically growing patients since it will worsen the profile. And in non-growing patients, the results are non-satisfactory, hence it is not indicated. And in patient, compliance is required for the success of therapy, so non-compliant patient, it is not recommended. Its advantages includes the elimination of abnormal muscle function, mainly buccinator and tongue, and also orbicularis oris. Now, the advantage over the activator is the less bulk of this appliance. Action is faster than activator since unfavorable forces are eliminated and also the wear time is increased. Treatment at an early age is possible. It can be worn full time. Less chairside time is required and less frequent visits are required. Disadvantages include the success of the appliance greatly depends on patient compliance. We have repeatedly coming to these points. Does not have good response in older adults since the growth is completed. The forces on individual teeth cannot be controlled and precise detailing finishing cannot be achieved. Hence, future fixed therapy is mandatory. Now, since it also produces marked mandibular rotation, it cannot be advocated in hyperdivergent patients. Now coming to the construction bite for bionator, for standard appliance, it is taken in edge-to-edge incisor contact if possible. But in cases of severe overjet, phased or incremental advancement is done. It is similar to how we talked about in the construction bite of activator, right? Following the rule of 10 and the rule of thumb. For open bite appliance, the construction bite is as low as possible, but slight opening in posterior region will allow the interposing acrylic to interfere with the tooth eruption. For reverse appliance, construction bite is taken in the most retruded position as possible. This is how it is done. First, it shows the normal position of the class 2 patients, and the second image is the forward positioning of the mandible, the sagittal advancement, and the bite registration with measured vertical opening. This is how it looks in the patient's mouth, and this is how we articulate it. Now coming to the trimming, Balthus referred to stimulation of eruption as unloading or promotion of growth, and prevention of eruption as loading or inhibition of growth. The concept is similar. Unloading means the removal of acrylic. So wherever there is removal of acrylic, in that direction, the movement or the growth of the interalveolar structures will occur. And wherever we are loading or we are adding the acrylic, there it will restrict the growth, right? So in regard to this, we'll talk about vertical eruption, distal eruption, mesial eruption, and expansion. Firstly, vertical eruption. Now the acrylic is left at the occlusal plane interdentally. Firstly, between the both teeth, the acrylic is left. Now the upper and lower molars are unloaded first. That means the acrylic between the molar region is trimmed off. This will cause an closure of the open bite due to the supraeruption of the molars. Now the lower premolars are unloaded while upper and lower molars are loaded. Now since we have achieved the amount of required supraeruption, we now load the acrylic between them, and now we unload the premolars and create an open bite there. Now this open bite will be then closed, and then the upper premolars are unloaded while lower and upper molars and the lower premolars are loaded. So basically we are creating this sequential form where we are first the trimming of the acrylic between the bite, then the open bite is created. We will allow the supraeruption, which will close the bite step by step, first in the molar region, then in the premolar region, and then complete occlusion is set. Hope that is clear. Now talking about the distal and the mesial eruption. For distal eruption, the acrylic should touch the mesial aspects of the teeth and the distal aspects are kept free. Now this concept we have already discussed in activator. It is similar to it. The area where the acrylic will be touching will restrict the growth, right? Movement, and the area which is free of acrylic, the movement will occur in that direction. For distal eruption, we will load it on the mesial surface. Acrylic will be present on the mesial surface while the distal surface is kept clear of it. And for the mesial eruption, the vice versa. That is, the mesial surface is kept free while the acrylic is loaded on the distal surfaces. Now coming to the expansion, the eruptive path of maxillary and mandibular molar is trimmed with a buccal slope. Now as you can appreciate in this hand-drawn diagram, I might say, the acrylic is having a buccal slope and the eruptive path of teeth is then in that particular slant. So this will cause the transverse growth or the expansion. Now wear time for bionator, it is one full day and night, but except while eating, and the time interval between the successive appointments is about 3 to 5 weeks. Trimming of the faces can be done as required. Now coming to the treatment effects, the skeletal effects include the increase in the mandibular length, improvement in the antero-posterior relation between the maxillary and the mandibular teeth, and the forward displacement of the mandible, which was the primary goal. Dental treatment effects include the labial tipping and the linear proclination of mandibular incisors, retrusion of maxillary incisors, increase in the posterior dental height due to the extrusion of the mandibular posteriors, and the maxillary molars. And in regard to the soft tissue, the facial convexity is decreased and the lower lip is uncoiled. Now, when we talk about modifications for bionator, we have minor modifications and major modifications. Minor modifications include Williamson and Hamilton and two shows in 1978. The image that you can appreciate is of Williamson and Hamilton. Now, major modifications include Bio-Olmes appliance by Erich and Annette Fisher, modification bionator of Schmuth, and California bionators. So this is the bibliography. The books I've collected this material from. Thank you, everyone. Hoping that your concepts are as authentically corrected as those states.